So, hi. I'm going to present today the chapter 9. It's a, I would say, fairly simple and short chapter. It talks about measurement bias, and it complements some of the discussions we had before in chapter 6, 7, and 8. Because as they mentioned, I think it was in chapter 6. So chapter 7 and chapter 8 are mostly related to different types of biases under the null. Specifically talking about chapter 7 has to deal with confounding or common causes, and chapter 8 is related to common effects, right? So selection bias mostly. Those have been like the main topics of the previous 2 or 3 chapters again. And in chapter 6, when they talk about the sources of bias, they also mention the measurement bias as well. So as you may guess from the name itself, it's just performing wrongly measured, recording wrong measures about different random variables, and then that mistake is going to introduce some bias in the final results that you may end up in the analysis, right? So they begin the chapter with this example of the looking up experiment, where you're in the street and you record whenever you look up, if the person walking besides you also looks up. But now just imagine in the case, for example, when people look up, the person that is taking the recording of the experiment forgets to note it down and maybe commits some error and writes it down the specific instance as if the person actually looked down. So you introduce a bias only for the people, for example, that are looking at. That could be an example of a measurement bias, right? So I guess the whole book up to this point, we have considered that all of the random variables that we have are actually perfectly measured, which is somewhat unrealistic in general. So for example, let's talk about, let's start with this simple case, right? So we have a drug, for example, that has to deal with certain type of heart disease, for example. And Y can be, or they use the example of liver toxicity, right? So we, in general, have considered that A and Y are perfectly measured, and that we're going to try to assess the average causal effect of A and Y, right? That is the usual thing we have here. But one can imagine that, for example, the treatment can be misrecorded or measured in this case. And some examples could be that we either get the information about the treatment in a posteriori interviews from the people, like we ask a person if that patient received a treatment so many years ago, and maybe he doesn't exactly remember, or maybe he gives wrong information, not willingly, maybe, but that could introduce some further error, and other sources of error can be thought of here. So, for example, just you can forget about something, you can record something wrong, or maybe you can introduce a data wrong in the database. For example, if you are coding everything with ones and zeros, maybe you can mistake at some point and switch it, or this type of conventional errors, I would guess. So it's very, very common to have this type of things, right? So the way they introduce these types of error is through a variable A star, which they consider the actual measured value of the treatment, right? So the real treatment that we're talking about in the ideal case would be A, but the measured treatment that we have access to is usually A star. And A star is also affected by, let me move this diagram a little bit further down. Is affected by different sources of error, right? And what we are going to call measurement error is going to be this UA. Okay, so UA is the measurement error of A. So this is like the simplest type of case that we have when we introduce some measurement error. Again, this chapter goes a long way to explain a lot of different cases on which you can introduce these different measurement errors and how can they affect the final conclusions of the analysis. But this is like the main idea of the at least the first half of the chapter, just introducing these measurement error variables, right? So here is like the simplest case because we are not considering any confounding factors, well, variables, or we are not even considering actually that the outcome of the study is mismeasured, but it can also be measured wrong again. So we can also do the same type of extension here, right? I could consider that there is, let me move this as well. I could consider that we have another measurement error related in this case to the outcome, which is defined in a very similar way. So this is the measurement error of y in this case, right? It's the same thing. So examples of these could be, again, for example, that you ask a person about the outcome of a certain treatment after some time, and it doesn't, this person doesn't exactly remember if the treatment worked or not, or maybe you're having these troubles extracting this information from like a long study or similar things, right? So maybe you even register some of the outcomes wrong as well in the database. So you have many possible sources, right? Some of them are easier to control for in this case. But some of them are just in most cases you have to consider these sources of error because you're not going to be able to.
What's the meaning of A star? I mean, it could be that UA leads, interacts directly with A, right? Like before.
Yeah, they use this convention, like you have like the ideal type of treatment, the real treatment. So this will be the ideal treatment, and this will be the real outcome. But this is like the measured treatment. And certain sources of error affect the measured treatment values. So they are encapsulating all of the possible measurement errors under this variable over here, and they combine this with the real treatment, if you want, the ideal treatment, into the measured treatment. And the same goes for
there are more assumptions there. They are also assuming that UA is independent of UI.
Yeah,
that UA is independent.
But that's something that we will get to like right now. Yeah. So this is like the simplest case. Like in the case that the treatment measurement errors are independent from the measurement errors of the outcome. But as Roy said, you can introduce also relationships between these two, or maybe the measurement errors with the lower variables, like the outcome and the
UA could be nothing. Because you are incorporating already the error with this A to A star transition, right? So I don't see what's the role of UA if you are already considering.
I think that what they are doing there is making it explicit that you observe A star as a function of two different things.
Yes.
The true A and a random error.
Yeah.
I actually found it easier to think about A as a just as a continuous variable and think like temperature, like there's a true temperature, and then your thermometer has a certain amount of noise. So the noise or whatever is happening it's on UA, and the true temperature is A. And the thing you record with your thermometer is
right.
That helped me to think about the problem.
So there are two different things then: what you measure and then the external errors.
Yes. Yes. You're encapsulating all of those external errors in the UA variable here, right?
Okay.
But not that one sense actually, but you don't even need to think about being able to actually. You are assuming UA and UY to be unmeasured and unmeasurable.
Yeah, in most cases, yes. But you usually use this convention over here because you are introducing like a structure over the measurement error, which is the thing we're going to discuss now.
Okay.
But could it be that UA leads to A?
Yeah. You can have
A
different relationships between the different variables here. We're going to study like in simpler cases, if you want, which is relations between the measurement errors between them, I guess, and also between measurement error and another of the variables that you have in your system. But we're going to see that like, right now. Yeah. So just no, let me so the thing here is that you're usually interested on the average causal effect, if you want, of A and Y, right? So this is, for example, this can be thought of as finding this, right? The causal risk ratio here. But this is, well, and in certain cases, for example, if the variables are perfectly measured and you control through standardization or inverse probability weighting, you can find this actually and make an assertion, find this equality over here. Right? You can do this type of things. This is the things that we have seen thus far, like in every chapter. So the thing is that usually when you introduce these errors, you have no access again to some of these cases, and you end up studying A star, the association, or the causation if you want, between A star and Y star. And this does not have to coincide with the previous one. So if you, for example, find the causal risk ratio here, Y star, let me use this. This does not necessarily equal the other, right? This is something that we can understand just from the whole diagram by itself, right? So this is like the general case. And this will lead, as we defined in previous chapters again, this will lead to a measurement bias. So since these two do not coincide in general, this could either enhance or dilute. This is the two terms they use specifically, the causal effect of the treatment on the outcome, right? Because this effect over here could be larger or smaller than the other one, so you would end up with a misrepresented conclusion in the final results, right? I'm going to move over here, I guess. Right. So in order to study like more complex structures of the measurement error, we are going to introduce two simple things, right? So let me just write as they do. This is a PDF, right? So a probability density function, right? And they explicitly define, I mean, it's quite intuitive, I guess, but they define two measurement errors to be independent as if the PDF of the two measurement errors factorizes over it, right? This means that UA and UI are independent. So nothing to know here. And they also define what they call non-differentiality. I guess maybe at some point I'll mistake the term with differentiability. It's differentiality, okay? Just in case I make the mistake. But what they call non-differential is this particular property right here. So this is equal to this. Okay? And this is equal to this. So
Should be conditional there.
oh yeah. No, let me.
Yeah, because I mean the joint is not necessarily.
No, yeah, you're right. Yeah, the joint is not necessarily equal to the other one. Yeah. So is non-differential and UA is non-differential as well. So they're using these definitions in order to make sense of more complex structures of the possible measurement errors, right? Because we are going to further complicate this diagram over here, introducing different relationships. So, well, different new arrows. So we're going to use all of these definitions in order to make sense of the different schemes or diagrams, if you want. So, as an example, in this diagram over here, you can see that UA and UI are independent and non-differential, right? So this is the first case. This is the simplest case possible, right? Because we have no dependencies between the two measurement errors, and also you have non-differentiality for both of the measurement errors that you have in the diagram as well. So is everybody in the same page here? Okay, this is something that we're going to spend just like right now. Another further complication, if you want, on that diagram would be simply introducing one arrow, right? So for example, let's imagine this case. I hope it's not too small, is it? Right, so this is the original diagram that I have over here. I don't know if I have colors, I guess not, but I'm going to use just different types of lines, right? So let's just imagine that I can introduce, for example, an arrow over here. Okay, I'm just writing it down in a different manner, so then I can do the opposite thing, because these two are going to be examples of the kind of the same behavior, right? So I just want to put them together somehow. So the interesting thing about the measurement error is that it doesn't have like a specific causal structure in the causal diagrams. For example, when we were talking about confounding, you can associate causal structure in the causal diagram to confounding errors, right? And selection bias also has a causal structure, because you condition, for example, on common effects or common preceding nodes in the causal diagram. But measurement bias doesn't have like a particular structure. Measurement bias is related to connections between different variables and measurement errors, right? And they can take many different forms. So this is the simplest case of a measurement bias, but you can further complicate this as well. So this is one of the examples, right, on which the result of the outcome affects the measurement error of the treatment in this case. So this can be a little bit tricky to come up with examples, but they provide 3 of them, and 2 of them are from the same kind of family, I would guess. So let me just so let's talk about what they call recall bias. And this is like a very particular example of recall bias. Recall bias, they provide an example on which, for example, A is alcohol use, Y is a birth defect, and the issue here is that instead of recording the things live in like during the 9 months of pregnancy, we measure birth defects after birth, and also we ask the mother in this case if she did consume any alcohol during the pregnancy. So we are sustaining all of the information about the treatment, in this case the alcohol consumption. We are having all of that information coming from a posteriori interviews with the mother, right? So since we are doing this afterwards, and we only do this, we only do this after birth, the the presence of birth defects will lead to a measurement error in the final outcome, right? They also provide another example. This is one of them, but another example they provide is in the case that, for example, Y can be dementia. This may be a little bit clearer. Y is dementia, and A is a treatment assigned by the people that are leading the test in this case. So if you ask the patient afterwards, dementia can also alter what the patient gives you, right? What the patient tells you that if it did work or it didn't work, right? So in these two cases, the issue here is that the recollection of past actions can have just because you forget about something, or maybe you want to hide some behavior, or maybe you want to lie and make you be seen in a better light. Maybe this could lead to a bias in this case. And these are different examples of what they call recall bias. And they also provide another example, which is called reverse causation bias, on which they provide another different example. So in this case, for example, they measure the blood levels of a drug. So this is the measured values. So this is going to be A star, right? This is going to be the A star because the drug consumption is going to be A, right? So the measured values of the drug in the blood is going to be an imperfect, if you want, mismeasured, possibly mismeasured variable dependent on the consumption of the drug previously, right? And the Y is now going to represent liver toxicity. But the key here is that you only measure the blood levels of the drug once you detect blood toxicity, liver toxicity, right? And liver toxicity actually affects the blood levels of the drug. So you're going to have this, what they call reverse causation bias, because the outcome variable in this case is affecting the measured variable here, right? So maybe this is another case that could be clear to find that type of structure over here. Okay. So I'm not going to remove anything, but I'm going to slightly change maybe I can do it in the same, well, it's okay.
Sorry, Simon, you said that toxicity, liver toxicity affects
Yeah,
the measure
of a drug. Yeah.
or the actual levels of the drug.
It affects actually the error on which you estimate the blood levels of the drug. So you would have this type of structure over here, on which the liver toxicity is affecting your precision in terms of measuring the blood levels of the drug in this case.
And at the same time, you said that you only measure
Once you detect liver toxicity.
So there are it's like two things going on. You will only measure only conditional on having some toxicity, and then the amount of toxicity is going to affect the amount of error.
You can simplify thinking about binary things if you want. So once you detect liver toxicity, you try to measure the blood levels of the drug, which is going to be like because since it's a posteriori thing, and also the drug levels in the blood are going to be affected by the liver toxicity because the liver is processing things. That introduces that reverse causation, if you want.
Okay, so actually you only measure. So there's also, I was getting confused because there's a temporal thing going on. You are measuring A star after.
Yes.
Okay.
The key here is that you measure liver toxicity. You only measure A star after detecting. So if you want, you can think about it like this if you want. So you only measure A star once you detect liver toxicity.
So the dementia example wouldn't be an example of reverse causation bias.
No, it would be a recollection bias
Recall bias.
or recall bias. Yeah,
Okay.
yeah. These are like two different
Okay. Thank you.
examples, like practical examples of this structure. And the complementary structure, if you want, would be just having this.
But for this one, you always need to have, like, thinking of time, you always need to measure A star after observing the effect. Otherwise, you cannot have, like,
Reverse.
For the reverse causation.
yeah, the time sequence has to be A, Y, and then A star.
Yeah.
Otherwise.
Yeah.
Because this is like this diagram is causal as well. Y is a cause of UA.
Yes. Of course, but you measure afterwards. So the causation is respected here, but the measures can be in different order, right?
Okay.
Yeah, but the definition of A star is A star at a time that
Yeah.
is after Y.
Yeah.
Because if not, you cannot have this structure.
Specifically, yes. In this case, they make special effort in mentioning that you only measure A after you detect liver toxicity. So the important thing here is not only the structure of the causal diagram, but the temporal succession of the measures, right?
But then isn't that also happening with recall bias? Because
Yeah.
so someone has dementia.
Yes. Since you're asking for a person to recall on the results of an analysis, that also plays a role, right? That is like a source of.
I think it could be more clear if they just say A star is whatever measure at this time, which is after the effect has been developed.
But
the thing is, in some cases, well, we're going to see another case afterwards, but in some cases, you ask about everything at the same time. You can ask a patient, for example, on the outcome and the treatment at the same time if you want, but it's after the whole study takes place.
But the time component is key.
Yeah.
But the time component is key to understanding both recall bias and reverse causation.
For me,
Yeah.
are the same.
Yeah.
Like for the structure in general.
It's the same
So
structure.
it's the same thing.
Yeah. It's
so
two
actually-
examples of the same thing.
So actually, why can't you say that the dementia example is also a case of reverse causation? Because you can think of once you have dementia,
I think
you change the value of UA. So isn't
They like giving names.
Yeah.
And
I
they
think
just
semantic
created
issue,
this,
right?
yeah, it's a semantic issue.
Yeah, I think it's just a matter of the other case doesn't seem to depend on recollections of anything, but I think it's just a definition, a name given to the very same thing. I mean, the structure is the same. So
okay.
causally speaking, you're talking about the same case, right?
All right. Okay, thank
Probably
you.
when they discussed the example originally, they call it recall.
Yeah.
Yeah,
Something.
exactly.
Probably the name
Exactly.
was before the
That's
theory.
right, yeah.
Right. Yeah. Maybe yes.
Okay.
Yeah.
As with compounding, that the name was
Yeah,
way.
it was.
Well before.
Yeah.
Right. Yeah. That may
They
be the
have
case.
different definition for the same compounding structure, so.
Yeah.
It's
Yeah.
basically the same.
And this example over here, I think is a little bit clearer if you want, because in this case the treatment is affecting the error of the final outcome. So one example they provide here is so imagine you have a treatment for patients that may be ill for something, and then since the doctors may be more cautious with people that are ill, maybe for those people that receive the treatment, they follow more closely, and they make less measurement errors than they make for a patient that didn't receive the treatment, right? So since, for example, a very expensive treatment, you want to make sure that you measure everything right, and for the person that you don't provide that treatment, or you provide a different treatment, you don't follow as closely, so that could induce a bias, right? And a measurement error in this case. So they don't provide a name for this one. They just leave it be. And I think that's much better, I guess. So these two cases are examples of independent. Well, I'm just going to write it once, but independent UA and UI. And in this case, they are differential. And you can see that in this case, UA is not going to be differential, and in this case, UY is not going to be differential because it also depends on the variable of in this case, of the outcome, and in this case, on the treatment and the outcome here, right? So in this case, the non-differential variable measurement error is going to be UY, and the non-differential variable here is going to be UA. That is simply following from the definitions above, right? Because if you respect the causal structure, you recover this result. So these are two examples of independent errors, but differential, one of them, right? And one can think that another possible example that they actually provide earlier is having a common source having a common source on both errors, right? So if you have this, you again can think that these two errors are now dependent, but both are non-differential. Okay. And that in that case, they are precisely dependent because of course you have this variable over here, and the non-differential instance in this case is because you don't have any direct arrows from the outcome and the treatment to the measurement errors, right? And in this case, they provide an example like you are trying to retrieve information from a faulty database, and the information about the outcome and the result are both coming from the same faulty database. For example, if the data is corrupted, maybe you end up with a correlation or a relation between the errors of the two measures, right? That is and also another example. So here you have like three different causal structures in terms of these definitions over here. So independence and differentiality. Yeah, that would be the name. Okay, so this is like the initial part of the chapter is mainly this thing. They also mention the importance about assessing the strength of the measurement bias, and that also depends on every single instance. So there's no like a general recipe for solving a measurement bias. I found one sentence in the chapter which I found I would say discouraging, if you want, which I wrote down like specifically, and they say the method to fight bias due to mismeasurement is obviously to improve measurement procedures. Yeah, okay. So that makes sense. I mean, if you want to have less measurement bias, you have to measure properly. That's essentially what they're talking about here. I found that discouraging in this case, to say the least. So, okay, let me just skip a few things because they talk about the strength and direction of the measurement bias. So you can think about, even in this simple case, the measurement bias could lead these two causal effect quantifications could lead them to be in opposite directions in some cases. Even in most cases, they assume, as we will see in a minute, that if the treatment has a monotonic effect, you can extract some further information. So we'll see this in a second. But in general, you don't have to have the same direction of the causal effect in this case or this case. More precisely, this being, for example, larger than 1 doesn't mean that this has to be also larger than 1. This can be smaller than 1. So maybe trying to assess the causal effect of two mismeasured variables can lead to different conclusions depending on the structure of your study and the structure of the errors and so on, right? So that is.
I actually found that kind of surprising, like that even in that case,
yeah,
because I always thought, okay, measurement error is going to lead to an attenuation. That's what I thought, but they actually say, no, you
No.
can actually flip the sign,
Yeah,
which is rather
yeah, you can think that
troublesome. I mean, it's,
if you're we're going to see another example in a second with confounders as well. But if in one of the, for example, if you stratify the analysis,
okay,
and in one of the strata you treat people differently, for example, you end up with unknowingly you end up with more ill people in the treated version than in the untreated one, and you don't know this fact, you can end up with different conclusions depending if you take this into account or not.
but that's like Simpsons, right?
Yeah, kind of similar. If you're not taking into account these possible confoundings that you should, but
Yeah.
are introduced through the mismeasurement, this
Yeah.
can lead to a reverse.
At least in theory, it's very easy to think of an example
of flipping.
like if you have a doctor and you tell the doctor, if you treat the person, put a 1, and if not, put a 0, and the doctor does the opposite, you will flip the. I mean, at least in theory, it could be. It's very easy to think of.
Yeah, that could introduce
That's flipping the sign of the
Right.
effect.
because the real treatment is the opposite. Exactly.
Yeah,
Yeah.
exactly.
Yeah. And he just registered every single entry.
So for every
wrong.
treated person, you register
Yeah,
them as
that's a good example.
untreated, and flips.
But that's not systematic.
Yeah, but it can be systematic in here.
Yeah, but
They
maybe
don't
you
say
end up-
nothing about the distribution of UA. UA is like they don't say absolutely nothing. They make no assumptions. They don't say that it has to be random.
No.
It's more.
Okay,
Yeah.
okay.
Yeah, in that case, for example, this can be 10 in that particular instance, but since the labels are switched, you end up with 0.1 in this case.
Okay, but for like in regular life, practical life, everyday life, that's sort of rather perverse, right?
I don't know.
But yeah, you can come up with examples of this. I mean, that can happen also unknowingly in some cases. If the label registering, for example,
I mean,
goes the
it's
opposite way.
extreme, but like for the theory that they are developing is.
Okay.
And this we will see something related to this with confounders. Now.
Okay.
But you can lead to this switching of the causal effect. Let me see if I can. So, another important point of the chapter is mismeasured confounders. Right. So thus far, the causal diagrams that we have used are pretty simple. They don't have any confounders or any exotic structures. But once you have confounders and those confounders are badly measured, you are in for some trouble, definitely. So the simplest case here would be this confounder, right? This is something that we have seen thus far. And let me just for a second consider that we are measuring everything perfectly. So in order to estimate the average causal effect, you would try to paint this, right? And this is simple to do since chapter 2, I think, or chapter 1, inverse probability weighting or standardization. So you have techniques to do this, right? But this depends on the fact that you're measuring everything correctly. So let's just, for a brief moment, imagine that we measure both the treatment and the outcome perfectly, but we have a confounder that we measure imperfectly. So we have a mismeasured confounder. So you end up with an L star, right? What is the problem right now? Usually, you only have access to this thing over here. And in order to apply all of those techniques, you need to be capable of blocking the backdoor path, right? If you condition on this over here, you block nothing. So if you have a mismeasured confounder, you're most likely going to end up with some mischaracterized average causal effect or whatever, right? Because again, if I block over here, I'm blocking absolutely no backdoor paths whatsoever, right? So this can lead to, of course, if I try to estimate this causal risk ratio, in this case, this is not going to be the same as in the original perfectly measured case. I'm not going to exactly write it down again, but that's it. And this also happens even in, well, they represent this extra case in which you have, so in this case, L is not actually the true confounder, but it would be like a surrogate confounder if you want. And there was a third variable here that plays a role that connects L and Y. And even here, if you have a mismeasured L, again, you are not capable of controlling this backdoor path. So in all of these cases, you end up with a measurement bias, right? And in this case, this would represent the measurement error of different variables here, but I'm not necessarily introducing so this is just to make an argument of how can you reorganize all of these causal structures in order to represent measurement errors in terms of different variables that you have not measured, right? Just unmeasured variables, if you want. So they mentioned that L can be thought of as a mismeasured or a measured confounder, or L star can be thought of as a surrogate confounder. Because if you study the effects, you will find the same structure you would find as a surrogate confounder here, right? So again, the key aspect of mismeasured confounders is just if you are mismeasuring a confounder, you're definitely out of luck in this case, because you're going to end up with a bias in the final results in most cases, unless you can control for it. Okay. So an example they provide of this, which I think is fairly illustrative if you want. So suppose you have a treatment and, for example, for all people with the measured confounder, so let me see if so A is the treatment again, and Y is, for example, liver disease. This is the example they provide. And for all, so you have this case in which the true measures of the true values of the confounder and the measure values of the confounder coincide in every single case for the measure one, but in half of the cases that you measure that there was no confounder, or the confounder took value 0, so the measurement was value 0, you actually had, in half of these, you had L equal 1, and half of these you had L equal 0, so half and half, right? So in this case, you are misrepresenting, if you want, the measured values for the confounder here. So only for this case. So when you measure, again, the confounder as a 0, you could have actually different values of the real confounder in behind the scenes, if you want. So you don't usually have access to this. And in this case, you're going to, of course, end up with a bias because you are mismeasuring the confounder, as we mentioned before. And the difference here is that even though the treatment has no effect, imagine a simple case. So let's just forget about the second one and come back to this one. So imagine this is a representation of that particular instance, right? And we are mismeasuring the confounder here. So even if for example, the causal risk ratio, if you want, of A on Y is 1, so you have no causal effect of the treatment on the outcome. Even if that's not the case, so you would remove this arrow over here, you would end up with a causal effect of the confounder on the other on the outcome variable, which would be biased in this case due to the mismeasure of the mismeasurement of the confounder variable, right? So this is just a further example of this. And again, they also mentioned, like, very briefly, that this is the whole discussion with the confounders is almost the same that we have considered thus far, because the key idea here is that blocking the measured variable does not block the backdoor path, and this also happens the same with selection bias. So if you have, I think you represented with a C, if you have a variable C, and in this case you have this structure over here, and you have a mismeasured C that depends only on C, and you measure here, you're inducing a selection bias as well, okay? Because you're conditioning on the measured value in this case, which is a descendant node of the original C node, right? Okay, this is like the initial, well, 2/3 of the chapter are just examples of this, and very briefly, we're going to see the final justification for the chapter is trying to find something useful besides all this, because I think for the most part, this initial part of the chapter can be summarized as just try to measure better things. That is what I take out from all of this. Right. So complementing all of this discussion on the failures of measurements, they have a whole discussion on the intention to treat effect. So right. This is something we also discussed. I think it was chapter 4 or something like this, maybe 5. I don't know if you remember, but intention to treat is simply trying to measure just the causal effect of the intention to treat a group of people. It's not directly related to the treatment itself, but only assigning a treatment to a group. Not the treatment itself. This is so in most cases, we have these type of diagrams of, in the end, we're interested in this relationship between the treatment and the outcome, but this also depends on the implicit assumption that we are having two values of the treatment, and the population assigned to a treatment, they keep that treatment for the whole duration of the study, for example, or they respect the treatment assigned to them. So what they now extend the model to is consider a new variable, which is represented over here. And we can discuss this arrow again. So they complement this original diagram with a assignment of treatment variable, if you want. This Z variable is going to be the treatment you assign to a patient, and the A variable is the fact that the patient ends up with the treatment or not. Okay, so the thing you have control on is actually assigning the treatment, but you don't actually, in most cases, you don't know if the patient ends up treating or not, right? Because you have all sorts of measurement errors here. For example, they usually talk about this in terms of adherence. So the key idea here is adherence. So if I assign you a certain treatment, will you play the role that I'm assigning to you? Like, are you going to seek a different treatment outside of the study, or are you going to not follow along the treatment as I recommended? I think a very clear example of this is, for example, when you're talking about giving pills, for example, to treat heart disease, and or even better, I guess, diet. I assign a diet for each patient, and I want to study the effect of the diet in the heart disease of the different patients, right? But if the patient does not adhere to the diet, then I really do not know how to assess this over here. But in most cases, I can talk about this relationship over here. So you have two different ways for Z to affect on A. So one way, of course, would be Z has an effect on A that then has an effect on the outcome, which this is pretty simple because I guess assigning a diet to a person is strongly related to the person following the diet, which then will have a causal effect on the final outcome, right? On the probability for example, having a heart attack or something similar. But also, this is the regular type of assignment effect that we would expect, but also they discuss that in most cases you also have this as well. And this is corresponding to behavioral changes that the population may have just by assigning the treatment itself. So for example, if you assign a certain diet to the people in a population, they may be more aware of their health and maybe choose to do things outside the diet to change the final outcome. For example, they may start walking more, maybe try to, I don't know, join a local gym or something like this. And this could play also a role in the final outcome of the final or the complete study, right? And they give names to all of these arrows as well. So taking this example into account, if you want, they talk about all of these arrows as, so this is the effect of the treatment. Right? This is the regular thing we're trying to find. These are behavioral changes. So they mentioned they are concurrent behavioral changes. And this is the adherence. So this is well, the key idea behind the intention to treat effects, right? Because just the pure intent of treating a population may alter the behavior of said population and alter thus the outcome of the study. Yeah, exactly. Yes.
Example.
Exactly. Yes. Yeah, I was thinking the whole time. I was thinking about this. Yeah. So there are some ways to control for this and to actually what they call decontaminate. Decontaminate the causal diagram here. And the way they mention decontamination, if you want, which would be removing this arrow over here, is fairly simple, I would guess. Is a placebo control effect double-blinded, right? Because, for example, if you have, let's go back to the pills, the pill assignment, right? So if this is a pill and this is a certain disease, instead of giving a pill to one population and not giving any to the other one, you just give a pill to everybody, and the control population will get a placebo pill. And you don't even tell the doctors who are receiving a control or a treatment pill. So in that way, doctors do not play a role by paying closer attention to ones or the others, and the patients they are taking something they don't even know if it's a treatment or actually a placebo, right? So again, this is one attempt of decontaminating the causal diagram, and this is what they call when we study. Well, that's a particular case, I guess. But when we study the effect of Z, this is what they call intention to treat effect. Right? That is precisely the intention to treat effect. Again, even if the treatment does not have a causal effect on the outcome, so even if I remove this arrow over here, if we do not decontaminate the diagram, you can have a causal effect of the intention to treat in the final outcome, the result, on the final outcome of the experiment, right? Even if I remove this arrow, of it, this A doesn't have an effect on Y, you can end up with a relationship between the assignment of a treatment and the final outcome. So that would be an example of swapping all of the pills with controls and just making people aware that we are giving pills to improve health, well, cardiovascular health in this case. So just by making people participate in this example and giving pills, even if the control and the treatment pills play the same effect, so they have absolutely no effect, you can induce a final, a non-null causal effect on the final, on the population just by making this same study, right? Yeah, I'm going to summarize very briefly the rest of the chapter because they end up with a lot of arguments on why this is interesting as well. But I think we can just summarize most of it. Okay. So one concept that is strongly related to this, I don't know if here. Is the per protocol effect. And the per protocol effect would be, it's fairly simple, I would guess. The per protocol effect is what is the effect of the treatment had everybody adhere to the assigned value of the treatment for every single patient. So this is essentially, let me just abuse the notation, but make the treatment and the assigned treatment the same thing. So this would be the effect you would observe if everybody in the population respected the assigned treatment, right? And this is something that you can obtain only in cases where both variables are essentially the same, but people, again, do not adhere to every single treatment we assign. So this is, in general, very difficult to estimate. So the fact is, if this holds, you can do this thing. This let me just summarize. Okay, so this would lead to an ideal experiment on which you can you have conditional exchangeability between the treatment and the effect, and then you can use inverse probability weighting to estimate all of the causal measures, because you know that the assignment you made originally are going to correspond exactly to the adherence of the people. Well, the adherence is one, so the treatment is the one you assign, and then you can estimate everything fine in this case. However, if A and Z do not coincide, so the important thing here is if they do not coincide, for example, let's imagine a case in which you have severely ill people, right? And And these people that are severely ill and you assign no treatment, they can try to find like a treatment outside of our own study, right? So for example, if you need a heart transplant and some other institution offers you a heart transplant outside of our own study, even though we didn't assign one to you, it's normal that you say yes to the other study, right? And they represent this through an extension of this diagram, which is this u variable over here, where u, in this case, will play the role, the severe illness. That we didn't take into account to assign the treatment that we had, and it's also affecting both if the people actually end up receiving a treatment and end up recovering, for example, right? So this is a third variable that doesn't play a role in our assignment process, and that also affects if the person actually received the treatment and how they recover. And this can also play a role, again, if I even remove this arrow over here. This can lead to an effect again, right? Even if Z and A are the same, essentially. So even if you have perfect adherence, if you exist, you can also end up with a final effect over there. But these cases exist in many different instances. They provide this severe illness effect. But the thing is, in general, trying to estimate the per protocol effect, which would be essentially when you don't have this U variable, so when the assignment of a treatment and the treatment followed by the person is exactly the same thing, that is also not very easy to estimate in most cases, right? So in many different cases, they satisfy, well, they are satisfied by the intention to treat effect. So this doesn't mean that the intention to treat effect is perfect. Again, this is not the effect of the treatment itself, but only the intention to treat a person with a given treatment, right? And they they spend like 2 or 3 pages providing different arguments on why this may satisfy most of the interesting questions that we may have about the treatment. But the truth is, there are certain limitations that we cannot account for. So they provide especially 2 arguments on why this could be interesting to study by itself, like the intention to treat effect, not the per protocol effect. The 2 justifications are, one, that it preserves the null. So if A has a causal null effects, I don't know if this. So they mentioned that this is sustained in most cases. So they argue that when A has a null effect on the final outcome, the intention to treat should also be the same. Especially if you have the sharp causal null conditions, on which you have like the null is respected for every single state of A, you end up with essentially, so all the, well, yeah, I can write it down if you want. Under the sharp causal null, this holds. Yeah. under the sharp causal rule. And in this case, the counterfactors and the conditionals are depending on different variables. So the two conditional distributions that we have over there are just conditioned on the assigned treatment, which is the thing we can control, and the counterfactors in this case correspond to the real treatment value that we have in every single case. But this is this holds under the sharp causal rule. That depends on the condition, right? And the second motive they provide to study the intention to treat effect is that, which is a fairly controversial point, I would say, but the value of the intention to treat effect is guaranteed to be smaller or diluted, if you want, compared to the real effect of the treatment. But that is what we were discussing earlier. This depends on the idea that imperfect adherence is going to dilute the effect of the treatment instead of exaggerating the effect of the treatment. And this depends on the fact that the treatment has monotonicity in its effect to the different populations. So it affects every single population the same way, in the same direction, if you want, and it doesn't reverse directions. Directions between different populations. So this is the key idea here. So the intention to treat effect is going to play like a lower bound on the causal effect of the actual treatment on the real outcome. This again, so this is one of the motives, if you want. And the second one, I'm going to use a little bit of empty space. The second one is lower bound on the per protocol effect, if you want, or on the effect of A on Y. So it plays a lower bound. But the lower bound, again, depends on monotonicity. It depends on monotonicity. If you have monotonic effects, it can be considered a lower bound if you're considering a case of treatment versus no treatment. But if you're just comparing two treatments to each other, that can lead to problems as well. So if you're not comparing, for example, the placebo pills with treatment pills, but you're considering treatment A and treatment B, this isn't that clear. But again, you would have to pay attention to the particular cases in head-to-head trial, as they mentioned. So they provide an example of let's just imagine head-to-head. So let's just imagine a simple case. For example, you have in this two pills case, right? You have one of the pills is just ibuprofen, okay? So it's a fairly cheap, inexpensive drug, if you want. And the other drug that you have in your experiment is very expensive. But they essentially do the same thing, but the expensive drug is also the new drug, if you want, also plays a role on diminishing some side effects, right? So maybe you have a condition and you have been assigned to either treat it with ibuprofen or try to treat it with this new expensive drug that may also lower some side effects. Those side effects do not play a role on the major condition itself. So if the expensive drug makes you adhere more because it removes some of the side effects, that can also lead to a difference, to a major difference, or this the intention to treat effect would not play a lower bound to the overall treatment. Because you can imagine an example in which these two drugs play exactly the same causal effect between treatment and outcome, but in this particular instance, since the the expensive drug had more adherence, the intention to treat would be different for one or the other. This type of structures can appear. And also a third caveat, if you want, these are like caveats of the lower bound. A third caveat is that it's dangerous for assessing safety. So if you're interested about the causal effect of a certain drug to treat a patient, that it's well and good if the two previous things do not affect your case, right? But if you're trying to study the safety of a procedure and it provides you a lower bound, and you think that your procedure is safe because the intention to treat effect is essentially non-existing, that can lead to an issue, right? Because the actual safety of the treatment can be lower than the one that it's provided by the intention to treat. So this can also lead to some issues, right? So again, they provide like 2 or 3 pages trying to justify why is it interesting to study the intention to treat effect instead of the actual treatment causal effect on the outcome. But again, it's fairly limited. You have to pay very close attention to all of these matters. And they mentioned that you have essentially a trade-off between trying to estimate the intention to treat effect, which is fairly simple, but it has a lot of caveats, and actually measuring the per protocol effect, but it's much harder, and you have to pay attention both to adherence problems, mismeasurements, etc., right? And I'm not going to go too far into the further fine points they provide, although I think one of them is interesting as well. So they, just to finish up, the per protocol effect is also in some cases called the efficacy of a treatment, and the intention to treat is the effectiveness. So this is 2 names they give in the literature again. And in some of the literature examples, they say that the intention to treat effect is actually more realistic to try to estimate than the causal effect of the treatment on the final value, because the intention to treat effect accounts for adherence problems and behavioral changes of the population. So that is the plus side. So that is the good side. The intention to treat effect accounts for those possible behavioral changes and adherence problems, right? But that also has a flip side. The flip side on this case is that the adherence on an experiment may be different than the adherence in real life, and may also actually be influenced by the same study we are conducting. So if I measure the causal effect of a treatment on an outcome variable, on for example, a health case, and I think that through this study, the intention to treat provides like the good causal effect, like the treatment helps, the intention to treat is positive, so this treatment seems to lead in the good direction. If the adherence in real life is higher because the people read the study we conducted, the final outcome will be different actually from the one we obtained. So that's also some interesting point to keep in mind in this case. This can also lead to refrain of using double-blind experiments, because for estimating the intention to treat effect, you don't need this double-blind, placebo, etc. experiments. So because you're accounting for these behavioral changes which are introduced in this arrow over here, so you would be like tempted maybe to reduce the double-blind experiments. And the third point they mention is that if I give you the real case, if you're a patient on one of these cases, you may be don't care too much about the intention to treat effect, but you would care about the real effect of the treatment on you, because you are going to be treated. So if you're a patient that is actually invested on a treatment, so I want to be treated because I'm ill, I have a certain heart condition. So I don't care about the intention to treat effect, I care about the treatment effect. And that is definitely, in general, is definitely not the same as the intention to treat effect. So yeah, there are like positive and negative sides to all of this. So it's much easier to estimate, and I think it's more robust when you talk about this, because it accounts for all of these sources of uncertainty and mismeasurement and possible changes underneath. But it also has like a flip side on which is some of these effects are much more difficult to control for, right? So that's mainly the whole chapter. I think I've gone a little bit longer than expected. So